Welcome back to the Dermcast.live studios as Rob Casquejo in Nashville, Tennessee, Music City, and I'm here today with Dr. Jeff Yu, and I'm very excited to talk to him, and welcome, Dr. Yu.
Thank you so much, Rob, for having me.
Yeah, and so welcome to Dermcast.live. Why don't you tell the audience a little bit about your backdrop? We're going to talk today about contact dermatitis.
So I'm an assistant professor of dermatology at the Massachusetts General Hospital, where I practice both adult and pediatric dermatology. I have a subspecialty expertise in contact dermatitis, where I spend most of my week patch testing patients looking for causes of their dermatitis, especially allergic contact dermatitis.
Okay, so this is really your thing. This is your where you really like to hang your hat in these diagnoses and problems. So let's talk about from a practical standpoint of clinicians who are seeing contact dermatitis. So very often we make a clinical diagnosis based on examination, say this looks like a contact dermatitis to me. So the broad approach when you first see a contact dermatitis, probably most of us believe that history is going to probably lay something out, but we run into trouble when we cannot pick up something in history that's obvious. So where do you go from there?
Yeah. So even to take a little step back from there is that most people coming in with what we think is contact dermatitis might actually present with what might look more like atopic dermatitis, especially when we're talking about children. As we know, atopic dermatitis is the #1 most common inflammatory skin disease that we see in kids. About 20% of them are all affected by atopic dermatitis. What becomes really difficult is to know how much of this is atopic derm versus how much of this is contact dermatitis. In adults, it's probably a little bit easier because if you have an adult that comes in and says, I've never had eczema for a day in my life, I started doing something new, going to a new job, going to a new setting or something like that, where suddenly I'm now breaking out in what looks like a dermatitis rash, then perhaps there is a little bit more clue as to this could be contact dermatitis. What I've learned over the last 6 years of doing this is that the history upon intake is almost completely irrelevant to what's causing their contact dermatitis, because usually then they wouldn't come to see you, right? If they say this cream that I put on my face is what's causing my rash, they have no reason to come in and see the dermatologist. Usually it's because they can't figure it out, or it's been going on for so long that they have no idea what it could be. They've tried eliminating everything, and sometimes it's one of those inconspicuous things that they're using, whether it's their shampoo, their conditioner, their makeup remover. And the other day I just had someone who was allergic to their wax that they use on their skin, but they never put 2 and 2 together until we did the testing and say, hey, it looks like you might be allergic to this chemical. Could this potentially be relevant?
So it sounds like, okay, so a little bit of dichotomy between the population of pediatrics and the population of adults. So again, I think you're right. I think often it ends up being something that they're using and don't suspect. So what is your approach to sort of siphoning that stuff out of their history?
Yeah, so I will usually ask them a very detailed history in terms of when did this start, what makes it better, what makes it worse, do you notice any associated factors? Now, patients will often say, oh, maybe it's associated with some sort of food I eat, could it be mold in the house? It's almost never one of those 2 things, but I think those are just comes to the forefront of our mind because we hear about it so often. What I usually do is then I will take a very detailed history when it comes to what kind of occupation are you in, what's your day-to-day job look like, especially if you're somebody who perhaps work in a factory or work on a farm or works in a car mechanic shop where you have a lot of exposures to potential contact allergens. I really like to tease those out. Now, beyond that, I really try to figure out what you're using. So I start usually from the top. So I say, what kind of shampoo do you use? What kind of conditioner do you use? What kind of hair gel do you use? Do you get your hair dyed, for example? And if so, how often? Do you get your nails done? And what kind of nail things do you do? Whether this is purely just painting, or we're talking about dip, or we're talking about gel nails, acrylic nails, things like that. And I really try to take a very detailed inventory of the things that you are using. Not because from that alone I can say, oh, it's definitely your nails or it's definitely your shampoo. I don't know that yet. But that's where it leads into something called patch testing, which is the gold standard and really the only way of figuring out what your contact allergen could be. And usually it's not something that we are suspecting from the history alone.
Okay, so before we talk about patch testing, I've seen questionnaires. Like when someone, if you send to a contact dermatitis specialist, they often have these sort of detailed questionnaires. Do you use something like that?
I do. Okay. I make sure that my scheduler sends them a detailed questionnaire before they come in, usually weeks before. This is for 2 purposes. One, it helps me because you're able to write everything down in the comfort of your own home, taking your time. You're not in front of the doctor. You're not pressed for time or anything like that. So you can really go around the house and take that inventory. The second part is that it really gets your mind going in terms of, I've been using this product for X amount of time. This is the new product, potentially could be doing it. And usually by doing that, at least it's on the forefront of their mind when they come in. So when I ask them the question, they can really quickly rattle off, oh, I'm using a Pantene conditioner, for example. I am using a Biolage hairspray, things like that. Sometimes people don't remember if they don't have the chance to go through a detailed inventory like that.
Right. So for clinicians who are not necessarily, often your patients are coming to you with this diagnosis of contact derm and they're asking you to sort it out. So for the ground level clinician, when we see these for the first time, we're pretty sure it's contact dermatitis, and we don't have time to question them. Like, is there a standardized form you use, or is it just something that you have that you've concocted through your experience in terms of these questionnaires?
Yeah, I think it's something that it's more of a specialty clinic questionnaire that we use, mostly because it's usually several pages long, and sometimes you have to know what to do with it or have something to correlate it to. Because to know what kind of shampoo and conditioner they use but not know what they're allergic to isn't really very helpful. I think what's more helpful would be having a list of potentially hypoallergenic products that we can often recommend. Products that we know have lower concentrations of certain types of allergens and are just safer for that patient. So sometimes you're saying, oh, this person definitely has a contact dermatitis of something, I just don't know what it is. There are, for example, if we're dealing with the face, so if someone has a rash on their face, I have a list of hypoallergenic shampoos, conditioners, face washes, face creams, moisturizers, things like that that they can use in the meantime while waiting to come in and get patch testing done, because the wait time could be somewhere between 3 to 6 months.
Okay, so that's a good segue into managing these conditions. Or let's say you may not be able to treat effectively because you know that there's something, it's an ongoing problem, and you know if patch testing is imminent, for instance. We know that management can actually confound the effects of patch testing. So what is your best advice for those of us who are treating this dermatosis? We think it's contact dermatitis. We have no idea. We can't distinguish a source, so we're going to send for patch testing. What's best management that will not confound patch testing?
Yeah. So usually we'd say systemic immunosuppressants like oral prednisone, for example, methotrexate, any of those medications that we use sometimes to manage people who have kind of flaring dermatitis in general can certainly confound patch testing. However, if we're talking more limited places, so if someone comes in with just an eyelid rash, you can certainly move them onto hypoallergenic shampoos, conditioners, face creams, sunscreens, things like that, and maybe treat it with just topical medications, whether it's a calcineurin inhibitor or a topical steroid, and that is certainly not going to get in the way of patch testing at all.
Okay, so you're okay mainly with topical regimens. And let me go a little off-label here because I know that probably some of us are doing this, but do you feel the same about, let's say, topical PDE4 inhibitor, topical JAK inhibitor, similar idea? Okay.
So patch testing always takes place on the back for the most part, as long as there is space on the back. If the patient is not applying any of these local immunosuppressive or immunomodulating medications to the location where we're doing the patch testing, we don't really care where you're putting it on. So if someone has flaring hand dermatitis, feel free to put topical steroids on their hands. That's really not going to affect the degree of patch testing or the reliability of patch testing on their back.
Okay, great. So let's talk about patch testing now. So I think, if you look in the average dermatology clinic, it may be hit or miss whether they do some type of patch testing, and they're often going to be using these sort of pre-made kits. So I'd imagine in your situation that you're probably creating patch tests that you're gearing them more towards the patient. Talk a little bit about your process of developing a patch test on a per case basis.
Yeah, that's a great question. So I think a lot of private practices, especially a lot of smaller volume practices who may not do as much patch testing, are going to use the pre-made test, which is called TrueTest, which includes about 35 different allergens as well as one negative control. These tests are great in that you can buy them, they're pre-made, you put them in the refrigerator, patient comes in, you open the foil packaging, you stick them on their back, and you go from there. So very easy, out of the box, great to use. The only problem with that is that it's going to miss about 40 to 50% of relevant contact allergens, so about half of the time you're going to figure out what it is that he or she is truly allergic to. In our clinic, we do something called comprehensive patch testing, where the core series, so every patient is going to get this. This is the core series that has 80 different allergens. These allergens are probing things such as preservatives, such as fragrances, such as textile dyes, such as different types of surfactants, things that make shampoos and conditioners and soaps bubble, for example, and other leading causes of contact dermatitis. Beyond that, if I know that you are a dentist, or if I know that you had dental work done and now you're having some sort of a lip dermatitis or burning mouth syndrome or something like that, I have a specific dental tray that I would add on to it. If I knew that you were an automobile mechanic, I have an oil and cooling fluids tray that I can put on. If I know that we're dealing mostly with a facial dermatitis and you use a lot of facial cosmetics, I have a cosmetic tray I can put on. So these are different ways that we can customize the patch testing to the specific patient themselves. What we always say is that the more you patch test to, the more likely you are to find the answer. Because there's nothing worse than going through a whole week of patch testing and then to know that there was more that we could have put on and that we didn't find your answer at the end of the day.
Got it. So it sounds like boutique patch testing is kind of what you're doing, which makes sense because we know that the allergens are not necessarily predetermined. They can be kind of anything depending on the person's backdrop. So let me rewind a little bit because I keep thinking about the scenarios that we run into as clinicians because they end up with you because we're pretty sure it's contact derm, but we just cannot figure out what it is. So at that level again of diagnostics or clinical situation, when do you biopsy? Do you prefer people are biopsied? Do you want to know that, okay, this looks spongiotic and looks like it might favor a contact derm? Do you want to know that before they show up or not really?
I feel like most of the biopsies are never helpful because I think if a pathologist looks hard enough at any sample of a dermatitis, they're going to see eosinophils. And when they see eosinophils, they're always going to put perhaps could be some sort of a hypersensitivity in the biopsy. Just because there are eosinophils present doesn't always mean that it's contact dermatitis. I've seen plenty of patients who come in with biopsies where we find nothing on patch testing, and at the end of the day, they just had run-of-the-mill atopic dermatitis that they successfully treat with some sort of a systemic biologic, for example. Hand dermatitis is one of those really hard areas where patients will come in with a rash on their hands and the biopsy will say something like psoriasiform dermatitis or spongiotic dermatitis, can't rule out psoriasis. So you never really know what it is. I find it never to be very helpful.
You end up with more questions often.
Exactly.
So that's a good point. So that brings to mind then, someone ends up in your clinic, let's say, one of these patients that are difficult, they end up in your clinic. Do you ever find a situation where I better biopsy this?
Absolutely.
Yeah.
So sometimes they will come in and, I can think of recent examples where a patient comes in with what looks like a facial dermatitis and then people are suspicious for glasses rims. So it kind of shows up on their malar cheek area. We do the patch testing, we look for plastic and glues, we look for different types of metals because they were thinking about glasses frames again. And then we don't really find anything relevant. She tries avoiding the glasses, doesn't get much better. We try treating with topical medications, doesn't get much better. And then over time, as she sends me these messages and photos of updates and I see her back in clinic, it starts to evolve a little bit where now it starts to look a little bit more atrophic, now it starts to look a little bit more scaly, and then the question that pops into my mind is this actually lupus that's presenting like this? Because both looks red, both look scaly, both looks like a rash, both look bothersome, and then that's when I do biopsy, and in that case, for example, it did end up being lupus.
Okay, so it's usually situations where it's almost like exclusion going on here because there's not something definitive and then the clinical picture changes. Okay,
right.
So going back to therapeutics, I'm thinking about how these people end up to you. How long is fair? What's a fair amount of treatment to give somebody in a situation of I think this is contact derm, I'm going to treat it? What's a fair amount of time to treat something before you say, all right, you need to be patch tested?
If it's truly contact dermatitis, you can keep treating it and it will never get better without the allergen avoidance. So usually what I tell people is let's try to avoid these allergens for the next 3 months or so. I'm going to give you a topical steroid and or a non-steroidal to kind of alternate the therapy a little bit, and let's see how things are. If it's truly contact dermatitis and you're avoiding the right allergen, usually within about the first month or so, you're going to know. Instead of that daily chapped lip or that daily scaliness on your eyelids, you're going to have many more days where your eyelids are almost completely clear, or all days when your eyelids are completely clear, and you can slowly taper off those topicals. So I would say within 3 months, if you don't know that if you're better or not, that's when we should really go back to the drawing board and see if there's something else going on.
Okay, great. And then the other thing that I think a lot of times we wonder is if we're trying to figure out a source, there's this question of, well, how long can a delayed hypersensitivity take or a delayed contact? So what time frame, is there a hard number to say it can't be that was too long ago? Or there's a time frame that you say it could be anything within this past time frame. Do you have any advice on that?
Yeah, I think it's easier to say what it can't be based on how short of a time frame it is. So what we do know is that delayed type hypersensitivity does not usually occur within minutes. So if you say, I ate something and I developed a rash within 30 minutes of this, it's much more likely to be a type 1 immediate type hypersensitivity. However, we know that contact dermatitis can appear anytime between 12 hours, 24 hours, 36 hours, 72 hours, 96 hours, or even longer. And I've certainly seen contact dermatitis develop a week or two after contact with that relevant allergen. So it's really hard to tell. And that's partly what makes the history so unhelpful, is that I can't remember what I did yesterday, therefore I'm not going to remember what I did last weekend or if there was a potential exposure that causes my rash today. So that's what makes it so hard.
And then that would be a situation where patch testing is really
Exactly
going to help you out.
Because more often than not, I find something on patch testing, and it's only after I say, hey, you're allergic to this, could there have been some contact with this thing which contains this allergen? And then sometimes patients will kind of think back and be like, oh yeah, there was that one instance where I put that on.
Okay, great. So I'm glad you started on the topic of hypersensitivity. So very often, contact dermatitis, we know, has certain clinical features, that we look for, sharply demarcated patterns, etc. When you look at these hypersensitivity type reactions, let's say including contact derm, the workup is not going well, can't find an allergen, but everything's still pointing towards hypersensitivity. So when is it logical to start looking at systemic sources of a hypersensitivity if it's not obvious that there's a contact going on? And I know it's sort of off topic, right, because they're different things. They probably present very differently. But what are the situations where you look at a contact, say, I don't think this contact, might be something that they're ingesting?
Yeah, that's really hard. Usually I would say if it was more of a systemic contact dermatitis, we would expect more of a diffuse rash that kind of shows up all over. I've certainly seen cases of systemic contact dermatitis where it's just the hands or just the rash around the eyes, but that's probably the minority. Most of the time I would expect a much more diffuse type of rash. Usually with other types of contact dermatitis, we're seeing more limited to certain body surface areas, whether that's just the back of the hands in terms of a glove allergy, whether it's just periorbital or around the eyes if it's a cosmetic allergy, whether it's just on the arms and on the legs if we're thinking about a clothing allergy. But typically with a systemic contact that's due to an ingested allergen, I'm really thinking more of a diffuse picture than not.
Okay, great. And so let me throw a scenario at you, because this is where if in my experience I've found to be somewhat confusing. So you have a patient, they present with what looks clearly like a contact dermatitis, very specific geography and anatomy and pattern. But it's so violent that they have, like an id reaction or more generalized dermatosis, so, spillover of immune reaction. So now, in that situation, if you have trouble treating them and you can't get them better, that sort of broader immune reaction is a little confusing. That's when I start to think maybe there is something, like you say, this is more diffuse, maybe there's something systemic that set this off. I had a patient like this very recently, actually, swear it was contact dermatitis, got nothing in patch testing and a referral, and it came back after treatment, and this more diffuse rash, but an area that was very specific. So, again, is this a situation where you just say, all right, let's keep going after something that might be externally sourced, or might you start thinking about something more systemic again?
For those scenarios, sometimes I start thinking about how can we treat this patient to make them feel better, because at the end of the day, that's probably what they're more interested in, as opposed to saying you're allergic to this and therefore avoiding this will get you better.
Yeah, I think you're exactly right, because that's what's happening in this scenario. He keeps showing up for more prednisone is what he wants.
Yeah.
So yeah.
Yeah, so I think it's hard sometimes to tell the difference between allergic contact dermatitis and atopic derm, and certainly I'm seeing a lot of atopic derm, especially in older individuals as well, who may present with this kind of full diffuse rash picture. Sometimes treating them with a systemic biologic like dupilumab, for example, and seeing if that makes a difference for them can be very helpful.
Okay, well, thank you for validating, because that's the direction I'm going, so I feel better that you validated my thinking. Okay, fantastic. So if you this is a little off topic too, but if you suspect that they have something like a drug allergy, and they're one of those folks that are, polypharmacy, they've got 8, 9 medications, Can you describe approach to how you sort of approach that situation where you have to try to sort through this list of things?
That's really hard. So I think in terms of drug allergy, certainly if that's the suspicion, we try to discontinue everything that they do not need to be on. Now, if this is a life-saving drug allergy, or I'm sorry, life-saving drug that they need to be on, and they have a mild drug reaction to it, sometimes maybe treating through it is preferable, especially when we're talking about chemotherapies and things like that. But when it comes to other types of medications, whether it's a statin, whether it's something for high blood pressure or something along those lines, we can usually get the primary care doctor to kind of switch the medication to a different class and see what happens. And usually in that population, I say give it 4 to 6 weeks and see if your rash clears. But this is really just shooting in the dark and seeing what can we stop, what can we potentially switch over safely for the patient. But that's a really difficult scenario.
Okay, great. Yeah, I think it's difficult for most of us. It's a tough one. Let me ask you one last question. I alluded towards patterns of contact dermatitis, right? So we see certain patterns, specifically eyelid or like by the waistline, you know, you think of nickel or the ears, nickel allergies, et cetera. Do you have any kind of source that our viewers might look or other clinicians may use to say, here are some patterns of contact dermatitis and what they usually are suggesting as an allergen?
Yeah, so that's exactly what I'm going to talk about today, actually, is different patterns on different parts of the body that could suggest different things. So for example, on the feet, one of my favorite patterns is looking for the sparing of the arch. Because if we're thinking about a shoe-related dermatitis, the arch is the part of the foot that actually doesn't come in contact with the shoe very often. So if you have strictly arch involvement, the likelihood is much less to be contact dermatitis because it could be psoriasis, dyshydrotic eczema, any of those other scenarios. Another one is the hand. So if I see a lot of interweb involvement between the fingers, for example, that's much more likely to be irritant contact dermatitis from, say, occlusion with soaps, over hand washing and such, as opposed to some sort of an allergic contact dermatitis due to gloves. I love seeing the back of the hands being involved more than the palms, because the back of the hands is more sensitive skin area. So if I see that, I'm definitely thinking soaps, hand sanitizers, gloves, things like that that could potentially do it. But there are various causes, and there are certainly patterns that can suggest, is this allergic contact dermatitis or a different scenario?
Thanks to Dr. Jeff Yu for coming into the Dermcast Live studios. It's Rob Casquejo in Nashville, Tennessee.